You understand that whether or not to take estrogen matters to your experience of perimenopause and menopause. But a question you might not be asked is how you want to take your estrogen. And the answer matters. Estrogen pills produce different effects in your body than topical estrogen via cream or patch. And if you want the best hormone replacement regimen for you, you need to understand what those differences are and that you have a choice. You're listening to the Health Courage Collective podcast, episode 236, How to Take Your Estrogen, Oral versus Topical. Welcome to the Health Courage Collective podcast, the show for women who are too busy to slog through hours of generalized, inapplicable, and often contradictory health information, but too smart to ignore that a few minutes of focused attention now can prevent years of suffering in the future. I'm your host, Christina Hackett, a pharmacist who doesn't want you to live on prescriptions, a certified coach specifically trained to maximize your potential, and a compulsive learner obsessed with preventative, cutting-edge, holistic, and integrative medicine. I'm on a mission to increase your physical and mental resilience so you can fearlessly look forward to your next 40-plus limitless years. Your time is now. Let's go. Hello, and welcome to another episode. I'm so happy that you're here today for the first episode of 2026. You are terrific. How is your board of directors? Do you have them all set up so that you can rely on them to give you some epic advice in 2026? It's amazing how much wisdom we can extract from the advice of people we most likely don't even see in real life. Important people have a board of directors to help guide their important work. I'm glad that you're one of those people now. Today we're going to talk about oral estrogen and why or why not to take it as your form of hormone replacement. I think a likely scene to unfold would be that a woman in her late 40s starts to have some unusual symptoms. She loves fabulous shoes and has amassed a lot of them over the years. She used to pick out whatever looked the most pleasing with her outfit, but lately she can only stand to wear one of a couple of pairs. She never used to have foot pain, but she has started having a very annoying ache in the soles of her feet. It doesn't get better, but it does get worse when she wears certain shoes. She's a busy lady with a lot on her plate. She never used to think about sleeping. She'd just go to bed whenever and not wake up till the next morning. Now she spends a lot of time staring at the ceiling and listening to the furnace and the water softener in the middle of the night. She's trying a new bedtime meditation and white noise app, but it's not helping that much. Morning caffeine has become non-negotiable just to function at a basic level. She can't figure out why her hair has gotten drier and more fragile despite upping her moisturizing game with hair masks and expensive salon brand conditioners. But most of all, she feels annoyed way more often than she'd like to admit. She cannot muster the patience to talk to her coworker who's a rambler anymore. Get to the point already. She thinks the girl at the bank is disgusting for chewing gum, and her husband's quirks that she used to think were charming make her want to jump out the window now. There's literally no reason to talk back to the television. Silence is golden for a reason. And why isn't he telling her about something interesting? He's so boring lately. And so is the rest of her life. She eventually starts to realize that maybe all of this is related to declining hormone levels. When she has what she thinks is her first hot flash one night while lying awake in bed, again, she makes an appointment with a friendly family doctor she's been to in the past a couple of times for sinus infections and mild anxiety. She describes her symptoms and the doctor asks her if she has had any fatigue or vaginal dryness, and she says, "Now that you mention it, yeah, I have both of those." They agree that her hormones are probably on the downward trajectory that's normal for a woman in her late 40s, and the doctor asks her if she'd like to try hormone replacement therapy. She says yes, she would like to try it to see how she feels and see if it helps. So the doctor asks which pharmacy she'd like the prescription sent to. Okay, bye. Later that day, she gets her friendly pharmacy text message saying she has 2 prescriptions ready for pickup. When she picks them up, it's only $20, so that's nice. Estradiol 1 milligram tablets, take one every morning, and progesterone 200 milligram capsules, take one at bedtime for 12 days out of every 4-week time period. Okay, so I just say that because it feels like a very likely story to me, which is why I'm sharing it with you. It's probable that she will benefit from these hormones taken this way, but is it the best treatment possible for her? Is it the plan that will give her the greatest possible outcomes and the lowest possible risk? I don't think so. I have my own biases that influence my opinions, and your opinion certainly doesn't need to be the same as my opinion. I just want you to be well informed enough to be confident in your opinion and approach so that you end up with the world-class hormone outcomes that you deserve and that are available to you if you do a little extra work ahead of time. There are multiple facets to a great hormone replacement therapy plan. I want you to understand all of them. So get on the priority list for my program where we'll get you intimately familiar with all of them. Click the link in the show notes or go to my website, www.healthcouragecollective.com, to get on the priority list. We'll get you confident in what you want to do about your hormones. The one piece of this multifaceted puzzle that we're going to talk about today is how to take your estrogen. The prescription in this story ended up being for oral estrogen tablets. It's pretty common. Oral estrogen tablets are very likely to be covered by your insurance. They're cheap anyway, so even if they're not, it's not expensive. Score. Taking a pill every morning is super easy and convenient. It doesn't affect anyone else, like your special needs son that you care for or your little dog Pimento. Isn't that a cute pet name? I fill a lot of pet prescriptions, so I get to see all kinds of fun pet names. And I have a patient named Pimento, and I think it's super cute. Oral estradiol tablets come in 3 strengths, so that makes it easy for the doctor to just pick one. Fortunately, estradiol is bioidentical, meaning it's the exact same estrogen molecule that your human body produces. Well, one of them, anyway, the most potent one. So what's the problem with the story that I told earlier? There are a few risks with taking estrogen. Causing breast cancer is not one of them. Feeding estrogen-sensitive breast cancer that is already growing could be. The biggest risk is developing a blood clot. Blood clots are no joke. Your risk is higher if you have a genetic predisposition to blood clots or have been immobilized, like even on a long flight or if you had surgery recently. But many studies have shown that the prothrombotic or blood clot promoting effects of estradiol come from the way the estrogen is metabolized in the liver. When we swallow estradiol, it goes from our digestive system to our liver and undergoes a bunch of changes and transformations, as does everything we take orally. Well, not everything, but almost everything. That's our liver's job. Changing estradiol into a bunch of different metabolites in the liver does a bunch of other things besides just increasing blood clot risk. Oral estradiol increases a type of estrogen called estrone. This is a potentially more dangerous form of estrogen. It's the more common form in older women who are not on hormone replacement therapy, and in people, both men and women, with a lot of excess body fat, because fat contains an enzyme called aromatase that converts other hormones like testosterone into estrone. The metabolites also increase triglycerides, increase CRP, which is an important marker of inflammation that you can look at on a blood test. It can increase your blood pressure, increase your risk of gallstones, interfere with serotonin metabolism, lower growth hormone levels, increase carbohydrate cravings, increase fat gain, and decrease bioavailable testosterone. None of that is good. Another problem with taking regular oral estrogen is that it's only available in those 3 doses. But you could cut the pills or take multiple pills, so maybe not being a personalized dose isn't really that big of a deal, not compared to all the other negatives. The majority of providers, especially if they're choosing oral estradiol tablets as an easy default, are not testing your hormone levels. That's the standard, not to test, because they don't think the reason to take the estrogen is to replace your estrogen that your body is crying out for in the form of symptoms of low estrogen. They think the only reason to take it is to calm those symptoms down. This is something I harp on all the time, but it's because I think it's such a big deal. We talked all about it just 2 weeks ago in episode 234, How to Get What You Want. When you start with the reason why you want to take hormone replacement, it makes the how to do it a lot more clear, and it helps weed out providers who aren't on the same page as you. The reason you want to replace your hormones is to provide all of your cells with the ingredients they need to thrive. in the form of what your hormone levels were when you were 30, because that helps prevent and drastically delay all of the chronic diseases of aging that are considered normal parts of aging for postmenopausal women, such as osteoporosis, muscle loss, decreased stamina, slowed mental processing speeds, dementia, reduced immune function, skin aging, coronary artery plaques leading to heart attack, fatigue, insomnia, loss of libido, pain with sex, increased risk of urinary tract infections, and more. Then you want to take your hormones at a dose that will supplement your natural levels back up to what they were when you were in your 30s, if you were healthy in your 30s. Which means you'll have to test what they are now and what they are once you start taking the hormones to see whether you've succeeded with that. And if you're mimicking what your body does naturally when you're younger, it also means not taking the same dose every day. That's a discussion for another time, but I think it's worth the hassle to take a different dose of estrogen every day throughout the month to mimic what your body produced when you were in your 20s and 30s. And of course, it also means that hormone replacement therapy means hormone replacement therapy and not just taking estrogen, which is what most people and providers believe hormone replacement therapy is. There's more than just estrogen. There's progesterone and testosterone and possibly DHEA and some other things. Another problem with taking oral estrogen that goes along these same lines of not being body mimetic is that because it gets sent through your digestive system to your liver and is processed there into a bunch of different metabolites, the dose you have to take is much higher than if you were to take it transdermally through your skin or a patch. A typical estrogen patch delivers somewhere between 0.025 to 0.1 milligram a day. Tablets are 0.5 to 2 milligrams a day. That's about 20 times more estrogen. With a cream or a patch or correctly done troche, which is like a lozenge thing that melts under your tongue, you get the small dose of estradiol that your body previously manufactured on its own when you were younger, delivered into your bloodstream, and no other metabolites. When you take oral estradiol, you do get some estradiol that your body is missing out on, but you also get a whole host of other things that were never part of your natural physiology. So it feels less body mimetic to me. When you're in your 30s, you don't naturally have supraphysiologic levels of estrogen being dumped into your liver that have to be processed, which results in significantly increased risk of blood clots, increased triglyceride levels, increased sex hormone binding globulin levels that decrease your available testosterone, increased risk of gallstones, increased CRP, the marker for body inflammation, increased carbohydrate cravings, and lower growth hormone levels. So why do any doctors prescribe oral estrogen? That's a question I've had for a long time. I just assumed it was laziness and ignorance across the board. I still think that for like 90% of the prescriptions I see. But there are a few exceptions. There's a group called World Link Medical that teaches bioidentical hormone replacement therapy approaches to prescribers, and they are all about evangelizing the use of oral estradiol. They think oral estrogen is the Severus Snape of hormone replacement. This doctor promoting these things, Dr. Neil Rouser, really believes that women should take oral estrogen. So he's doing his best to spread his message of swallowing your estrogen as the way to go. His claims are that, quote, oral estrogen passes through the liver to improve cholesterol health, and that oral estrogen provides maximum cardiovascular protection. This feels wrong to me because two of the most important markers of your cardiovascular health are your triglycerides and your CRP level, and oral estrogen increases both of those. He says, though, that lots of studies show that oral estrogen has more of a beneficial effect on LDL levels. And he says that while a study called the Women's Estrogen for Stroke trial showed that oral estrogen increased both blood clots and blood vessel inflammation, which is way not good, that was with oral horse estrogen, Premarin, and not oral estradiol, so it's okay to use oral estradiol. This all feels pretty sus to me. Do people say that anymore? I don't think so. It's probably 3 years ago or something, but it is sus. When digging in a little deeper, I found a really good article written by a doctor named Amy Killen. She was trained by Dr. Rouser, and she does an excellent job of laying out all the evidence that has led her to believe that oral estradiol is the way to go. I'll put a link in the show notes. I think it's worth a read if you're interested in this topic. It's 13 pages long and really well organized with links to studies and everything. Here's a quote from her that made me start to question my long-held personal belief that no one should ever take oral estradiol. To wrap my head around the risks and benefits of oral versus transdermal, I did my own research, creating detailed spreadsheets and going through all relevant studies myself. I didn't rely on summary statements or meta-analyses. I went to the primary research. This article results from that research, which has taken me almost a year. Pretty good, Dr. Killen. I'd recommend you check out her article if you're interested in all the details. She has tons of links to studies, and it's a great resource. She goes through all the evidence showing that transdermal estradiol is definitely the safest form of estrogen to take, noting studies showing that even women with known clotting diseases who took transdermal estrogen didn't have an increased risk of future clots. She then presents an analogy saying, which is safer, water or antibiotics? Obviously, taking water has fewer risks than taking antibiotics. But if you have a bacterial infection, it would be negligent to take just the water because it's safer. You take what will give you the benefits you most need, not just what's proven to be safest. Dr. Killen's main argument is that we don't have enough evidence that taking transdermal estradiol as a cream or a patch has the same cardiovascular disease prevention benefits as oral estrogen. There are more than 50 human studies showing that starting estrogen within 10 years of menopause in women without atherosclerosis yet reduces the risk of future cardiovascular disease by 30 to 50%. That is huge. She says, though, that she believes that the benefit comes from oral estradiol and not transdermal, because the biggest studies are on oral estradiol. It's true, they are, because that's what most people use. That doesn't mean that transdermal estradiol isn't as beneficial. It just means that we don't have the evidence to prove that it is. That's a statement I think Dr. Killen would agree with. She chooses to prescribe based on the evidence, which I agree is good judgment. She does list a study in Denmark of 600,000 women showing that transdermal estradiol actually reduced the risk of heart attack more than oral estradiol, but it wasn't a randomized trial, so she thinks it's not great because of that. And a study of 6,000 women that showed oral and transdermal performed the same for cardiovascular risk, but she said the transdermal group was only 20% of the hormone users, so that doesn't count either. Not sure why not. She talks about how oral estrogen is better than transdermal at reducing LDL, total cholesterol, and she says Lp(a) and ApoB. But it does increase your triglycerides. If it's in fact true that oral estrogen reduces ApoB and Lp(a), I don't know that we have overwhelming evidence to say this is a fact, and you know for sure that you have high ApoB and or high Lp(a), but not high triglycerides, this would for sure change my mind about whether I think you in particular should use oral estradiol instead of topical. We talked about ApoB and Lp(a) in episode 171, What Smart Women Know About Cholesterol. In case you're wondering what it is, it's a way better predictor of your risk of the number one killer of women, which is cardiovascular disease. It's way better than total cholesterol or LDL cholesterol, which are almost meaningless by comparison. And most of the studies showing the cardiovascular benefits of oral estrogen say that it lowers your LDL, which doesn't matter. Whether your Lp(a) is high or not is mostly just genetic. So if you know you have high Lp(a), you should do something about it. And it's one of the few things that lifestyle modifications are not going to be enough for. So oral estradiol might be a good option for you. Dr. Killen talks about how she thinks the increase in CRP, that inflammation marker that you can see on a blood test, isn't a problem because it's just an increase in a lab value with no evidence that there's actually any increased inflammation in the body. She talks about how she doesn't think that the increase in estrone, that riskier form of estrogen, or in sex hormone binding globulin that binds up your testosterone so you can't use it, is really a bad thing, and that the overall risk of blood clots with oral estrogen is pretty low. It's lower than that for birth control pills, which we pass out like candy, which is true. And she does say that in a patient of hers with an increased risk for blood clots or a history of blood clots, she does use transdermal estrogen rather than oral. The main takeaway from her article is that both oral and topical estradiol improve menopause symptoms, reduce your risk of cognitive decline and dementia, improve bone and muscle health, skin health, pelvic floor health, blood glucose, insulin sensitivity, and all the other things. It's just that she believes that the evidence we have is clear that oral estradiol is better at reducing the risk of cardiovascular disease. She's right that cardiovascular disease is a big deal. Cardiovascular disease is the number one killer of women, so reducing your risk of it is the biggest lever you can pull to put more years lived in good health into your future. I hope you're starting to formulate your own conclusions about how you want to look at and think through all of this, or are determined to dig in a little bit deeper to decide what you think is best for you. Here's what I think. You can take it or leave it, but it might give you a jumping off point. I used to think that oral estrogen is always bad and transdermal as a cream or a patch is always better. There are also these troches, the thing you put under your tongue, and pellets and injections and vaginal delivery, by the way. We can talk about the risks and benefits of those some other time. Avoid pellets at all costs, though. I'm going to stand by that recommendation. Anyway, but here's my new thought process. It's possible that all of the liver metabolites from taking oral estradiol, not Premarin, but estradiol, will help improve your risk factors for developing cardiovascular disease, such as ApoB and Lp(a). You can learn more about those in episode 171. So if you know for sure through testing that you have high ApoB or Lp(a), and your main goal in replacing your estrogen is to reduce those cardiovascular disease risk factors, you should consider putting supraphysiologic doses of estradiol through your liver to produce those metabolites. I think if that's your main concern, you should get your ApoB and Lp(a) and full lipid panel tested before you start taking hormones, and again, after you've been on them for a while, to see if what you want to have happen is happening. You could run an experiment on yourself and do it with transdermal estradiol. It's possible that it might help just as much. We just don't know for sure. And if it doesn't, then do it with oral estradiol and see if that makes a noticeable difference. If you can tell the difference between the oral form and the transdermal form in yourself on your own cardiovascular markers, that's for sure the way you need to go. A 30 to 50% reduction in cardiovascular disease is a big deal, which the estrogen studies show, both topical and oral, but there are more studies in oral estrogen. Statins, which I am not a big fan of, might reduce your cardiovascular risk by 20 to 30%, maybe. So as a preventative treatment, I'd definitely lean toward oral estradiol over a statin for women who don't already have atherosclerosis and are within 10 years of menopause. But to me, initiating a preventative treatment for cardiovascular disease is different than naturally replacing the hormones that you've lost to give your physiology as close a replica as possible to what your hormone levels were in your 30s. Topical estradiol, especially at doses that change throughout the month, is way closer to what your body did on its own during your younger years than swallowing large amounts of estrogen and having to detox it through your liver. So it all goes back to your main goal with replacing your hormones. And maybe your main goal should be to do everything you can to reduce your risk of cardiovascular disease. If you test for those cardiovascular disease risk factors and they show that you're at an increased risk, oral estradiol might be a good option for you as a treatment. If you don't already have atherosclerosis, are still within 10 years of menopause, and don't have an increased risk of blood clots or gallstones. But it's not body mimetic, so to speak. So in my opinion, transdermal is still the best way to go for the majority of women who want to mimic their body's natural younger hormone levels. But oral estradiol is a valid treatment option for women who are specifically needing an unnatural intervention to reduce their cardiovascular risk and meet risk criteria. We don't have evidence to show that oral is definitively better than transdermal for cardiovascular risk protection. We just have more studies that use oral estrogen. So if you find yourself in a situation like our story at the beginning of the episode, and you go to the doctor about perimenopausal hormone issues, and she just thoughtlessly writes you a prescription for oral estradiol or says that's what she's going to do, I would still be very wary. If her reason for choosing that option is laziness or automaticity, that's not a good enough reason for you to take oral estrogen, in my opinion. But if she says something to you along the lines of, I did my own research and spent almost a year creating my own detailed spreadsheet and digging into the primary research, not just the summary statements, and I deeply believe this is the best option for you, then that's worth paying attention to. You may or may not end up agreeing with her based on your personal cardiovascular risk profile, but it's a whole lot better than, here, take this. So back to that article by Dr. Killen, she says, quote, in summary, if all of the stars have aligned and I have a low risk for blood clot woman who is within 10 years of menopause onset and who understands that there may be an increased risk of blood clot with oral estradiol compared to transdermal, I will preferentially use oral estradiol. And if I see more evidence that transdermal estradiol is as effective in cardiovascular disease prevention, I'll be happy to reevaluate my approach. But for now, I have to follow the evidence and go where it leads me. End quote. I so appreciate organized and well-presented thinking. It's one of the most delicious things to me. In my old age, I've come to be way more grumpy and less tolerant of rambling, which is often not very kind. I mean, just inside my own mind, which still doesn't feel good. But I'm also more appreciative of orderly and organized insight, especially when it also gives you a mental framework to come back to, which Dr. Killen did very well. I don't totally agree with her, but her logic is sound. I'll use her analogy of the water and the antibiotics. She thinks that because the evidence showing the benefit of the oral estradiol, the antibiotics in this metaphor, are worth the risk and are the better choice than the water. I think that since the water is safer and more body mimetic, it's the better default choice for everyone. And only in the case of data to show that the patient really needs to intervene with a foreign process, the antibiotic, meaning the oral estradiol, is a good treatment option. Like Dr. Killen, if more evidence comes to light, like a head-to-head study between transdermal and oral estradiol on cardiovascular events like heart attacks and strokes, or ApoB numbers, or something that shows oral is definitely better than transdermal, I'd be happy to change my opinion. Because cardiovascular disease is the number one health risk for women after menopause, and preventing it is huge. And estrogen is our best bet there. What do you think? I hope this was helpful for you to walk through. I believe that knowing why you want to take hormones and what a world-class hormone regimen looks like before you go to the doctor seeking help will drastically improve your chances of being treated at an elite level. It's unfortunate that not every woman has access to world-class hormonal care, but you don't have to be a celebrity with people who have people to get top-tier treatment. You just need to be able to recognize a world-class hormone approach when you see one. Oral versus topical versus sublingual versus injectable versus vaginal estrogen is one piece of that puzzle. If you want to learn more so that you can get through perimenopausal medical appointments with confidence, click on the link in the show notes or go to my website and get on the priority list for my new beta program that will help you understand how well-done bioidentical hormone replacement therapy is put together. Thank you so much for being here today. You are fantastic. Next week, we're going to talk about how to increase happiness in any area of your life. Until then, be thoughtful about the form of estrogen you choose, and it'll be normal. Thank you so much for tuning into the Health Courage Collective podcast. I am truly honored that you have paid me the enormous compliment of your time and attention. I would be so grateful if you would share this podcast with someone you know and subscribe so you never miss an episode. This podcast is for entertainment and information purposes only. Statements and views on this podcast are not medical advice. This podcast, including Christina Hackett and producers, disclaim responsibility for any possible adverse events by use of information contained herein. If you think you have a medical problem, consult a licensed physician.